Okay. Well, everyone, hello, good evening, and welcome to our final episode of the Family and Researcher Roundtable for this series. My name is Casey Craig. I'm the Executive Director for the Cute Syndrome Foundation and the mother to Stella. And I am so excited to have a special guest here with us today. You've probably seen him around the SCN8A community, and if you were at our gathering last year, you may have even had some interaction with him with some assessments with your own kiddo. But we have here today Sunanjay. Okay, let's see if I can say it. Bajaj. Did I say it right?
Bajaj.
No, Bajaj. I was like, I think I practice it too much, and then I got nervous. But we can call you Sunny for short. I know a lot of people do, but he is our resident physician at neurology at UT Health at Houston, and he is going to talk to us today about some different movement disorders. So I think most of us can probably relate that we have some type of movement disorder with our kiddos. I know Stella has several. And I thought there would be a really good opportunity to have Sunny here with us today to really kind of talk about the specifics of different movement disorders, show some videos. And what I hope that you get from today is that either A, it solidifies of like, oh yeah, my child does do that, and this is the name for it. Or you might look at some videos and go, "Hey, my child does that, and I don't know if I we have that diagnosis yet." And so I'd like to have an educated discussion with my doctor about it. Now, Sunny had said that this is definitely a conversational webinar, so feel free to jump in with questions if you want to come on camera, or if you want to come off mute, or if you want to type it in the chat. We would love to have any questions that you might have. So with that said, I will hand it over to Sunny.
Perfect. Do this. Yeah, thank you so much. Let me just get it set up. And just a minute. All right, are you able to see my big screen?
It's perfect. Yep, looks great.
Perfect. All right, let's start. All right, thank you, everyone. Thank you, Casey, for the introduction. This is a picture of Memorial Hermann Hospital where I work mostly. So I'm at UT Health, but we work at this hospital right here. The park looks a little different now, but it's still a beautiful picture, I thought. So. And the first part, so what I want to do in this talk is give more of a talk that is tailored to, as Casey was saying, you guys' needs. And I wanted to emphasize why movement disorders matter for us as physicians who are taking care of patients with developmental disorders, but also for you as family members to recognize why they exist. So I want to talk about first a little data-based information about why movement disorders matter. So as we know, SCN8A variants and a lot of other genetic or monogenic developmental disorders do have a diverse range of disorders they can create. And there's very good evidence from SCN8A. So there's a recent paper from April by Dr. McKee and group, where they describe the natural history of SCN8A related disorders, and other papers as well, where they look at the spectrum. And within the spectrum, among the major phenotypes that we always have, like seizures, developmental delays, movement disorders are one that are often mentioned, but kind of underrepresented when it comes to recognition amongst family members, but also in clinical trials, because these are difficult to describe and often not well objectified, which is, of course, one of the things that seizures can be done. So, like, how many seizures are you having? One, two, three, four. Whereas movement disorders, you don't really know what is severe or not, especially as a family member. And when you look at that same paper that I was talking about earlier, it really shows. So what they did in this paper is they looked at clinical notes, so actual clinical notes for all the visits that patients have, and did what they call some human phenotype ontology. So they just extract the notes and see what terms come up most frequently. And what they see that abnormal muscle tone and abnormality of movement is actually very, very highly referenced across notes. So you can see the frequency of how often it's there. It's almost omnipresent, just like seizures and just delays. And it's not just in the terms, it also, this is from an SCN2A related paper, which is of course a very similar disorder, where you can see that movement disorders, and you'll know best, tends to really impact the activities of daily life and the way our kids can interact with the environment and show their behavior. So it impacts their ability to sit on their own. It impacts their ability to communicate due to pain. And it also impacts, in general, all other activities that they can do. So overall, this, of course, leads to a reduction in quality of life and something that is an aspect that is almost like a degenerative, basically, aspect of these disorders. So they add on these symptoms over time rather than emerging with these symptoms as soon as they come out into the world. So this is why movement disorders significantly contribute to the disease burden in these patients with neurodevelopmental disorders and need to be characterized further. And this disease burden can be a spectrum, which is why it's also relevant for this talk to talk about what severe symptoms look like and what mild symptoms look like that may not be clinically apparent. And that is on the spectrum that I like to describe, where you can have severe disability but no deficits at all. But all of these may still go hand in hand with each other. It does not mean that someone who has severe disability will never be able to attain clinically inapparent symptoms. And which is why we don't really know how to characterize them better. And that limits the identification of patients that would benefit from a clinical trial. And we also don't know which type of gene variations or gene changes are more prone to create these kind of movement disorders. And overall, this has also been recognized across the scientific community. And of course, Casey was part of leading the SCN8A research consortium, where families presented their major issues that they deal with. And one of the critical knowledge gaps that was identified by the consortium is that there's a lack of biomarkers to track disease progression or treatment response. And of course, a lot of the times, seizures are the number one aspect that are covered in these disease progression biomarkers. But there are no real biomarkers to track movement disorders specifically. So we need reliable and objective and also scalable biomarkers that can be used for clinical trials. And specifically for movement disorders, you would want to see how they impact the daily function, the quality of life, and whether we can identify these endpoints more readily. So before I move into how we address this issue and what's going on, I think this is the part of the talk where I'd like to go into movement disorders in general and see, like, how do movement disorders emerge? Why do they even emerge in neurodevelopmental disorders? So to talk a little bit about the anatomy, I know that a lot of the talks may not have pictures of anatomy and brains, but I wanted to bring that in to show you where kind of these disorders come from. So we'll focus on the left here first. So this is like a cross section of the brain, kind of if you cut it through the middle, this is what you'll see. And there's different lobes of the brain. There's the frontal lobe, there's the parietal lobe, there's the occipital lobe. But the things that are most important for movement disorders or that can create deficits are, one, the cerebellum right here. And the cerebellum is the back of the brain and typically associated with coordination. So it helps coordinate movement between different muscles. So basically, whatever movement is going to be activated by the brain has some kind of impact from the cerebellum, which coordinates movements between agonists and antagonists of muscles. So say, for example, you want to use your biceps, your triceps has to loosen up. That kind of is the cerebellum. So it really needs the cerebellum to basically tell the other part of the brain that's kind of stimulating the other muscles to, like, hey, this one needs to be relaxed so that we can really lead the hand to where do you want to go. So you can imagine someone who wants to eat really needs to move the flexor more than the other. So if they don't have that coordination, you could get like kind of a tremory kind of movement. So that leads to, of course, a lot of what we call ataxia. So if you think about ataxia, a lot of times cerebellar dysfunction is what can cause ataxia. And the same thing is for eye movements as well. Eye movement disorders go a lot of times hand in hand. So you'll hear about disorders that are like where there's a lot of eye movement disorders, they will often have ataxia in combination as well, because eye movement is very, very delicate and coordinated with the cerebellum. And now the second major center, just to simplify here, is the basal ganglia region. So what the basal ganglia are, they're deep structures. So instead of being like at the surface level, they're very deep inside in the middle of the brain, basically. And you can see there's multiple components, and I won't really go into detail about these components. But what they do is they actually act as breaks or stimulants of movement. So they control the tone, they control the amplitude, so how much movement there is, and the rhythm. And these are the kind of structures that you'll hear about from disorders such as Parkinson's disease in older individuals, where there's degeneration over time. And this leads to dystonia and chorea. So these are more complex movements where there's actually an increase in tone. And I'll talk about them next and show you what that looks like. But basically, you have these two major centers that are kind of going on. And it's hard to know right now for sure which genes will contribute to one or the other. And sometimes we don't even know why some things that are like degenerative in nature, like how you'd expect in older individuals, are happening in our kids with neurodevelopmental disorders. So that's one of the key things that I would like to discover as well as we go along. So moving on to what these disorders look like. So I'll go by one to different kind of movement disorders and have videos. And all of these videos are actually me myself, as you'll see, at the different various conferences that we've been through. And we'll talk about that later. And you'll see kids that I have seen across the ranges. So first I'll talk about hypotonia. So if you remember, I didn't really talk about tone hypotonia much because hypotonia technically is not a movement disorder. What it is the lack of enough neuronal stimulation to generate basically a basic movement or basic muscle contraction that is always present. So all of us have a certain muscle tone that is present all the time, which is generated through early cortical development, which is often dysfunctional in our kids. So there's no real generation of a normal tone. So they basically start at a lower threshold. And why it is important is that it is always found early, and because you don't have tone, you have secondary movement disorders that add on top of the tone. So say, for example, you're super hypotonic, and I'll show the video now to showcase what I mean, is this is a small kid around 1.5 years old, and she's sitting. But as you can see, I'm kind of holding her the whole time. She's kind of slumped over. There's like a bit of an arch to her. And as soon as I let her go, she's kind of falling back right into my arm. Then she's kind of smiley and very funny, but like you can see that she's swaying to the right, she's swaying to the left. There's no core tone here. So there's a primary disorder of core here, or core hypotonia, because her bulk muscles from the stomach or from the back aren't really developed very well. Oh, what happened here? Oh, so there's a part where she was going to stand up, which has been wiped off. But basically, when she stands up, you see the same issue that basically she sways around and she can't really hold up. But what I want you to focus on is look at her legs. So she has clearly axial hypotonia or core hypotonia, but you can see that even her legs are kind of bent. And you can imagine right now she's very, very loose. Hypotonia means basically just loose muscles. She's kind of loose, so they bend. But as over time she grows into it and she starts developing a tone, this abnormal posture kind of can fixate itself and then become like a bent posture, which is what hypotonia is critically something that we care about. Because over time, the postures that the person takes early on can become ingrained, and then you can have secondary movement disorders and the first something like a dystonia, which we'll talk about shortly. So this is why hypotonia is important to note, because it's often a very early onset kind of feature of movement that we see in a lot of our patients. So next I want to talk about ataxia. So as we talked about earlier, ataxia is mostly or often related to the back of the brain, namely the cerebellum. And ataxia by itself sounds complex, looks Greek, but it basically just means lack of coordination. And it could be coordination in anything, coordination in standing, coordination in sitting, coordination in walking, in fine motor skills. So it's very useful to describe in general how much a person can basically do with balance. So it's all about balance. And there's two ways to look at it. One, you can look at it for gross motor function. So you can just have a kid sitting and see whether they sway, see whether they have perception of space. So that's one thing. I see some chats are already coming in. Okay, no, okay. My daughter has ataxia constantly, but episodes of worsening ataxia. Okay, so I'll get the chat here as well. Yeah, so I think So there's two different types of ataxia. The ataxia that is constant, and then there's a thing called episodic ataxia. And those are two different kind of metals of the same kind. Uh, yeah, and then the second question is SCN8A related ataxia considered a genetic ataxia now? Yeah, so I think by definition, any genetic disorder that can lead to, or that is shown to do movement disorders, can be categorized as a genetic form of ataxia for sure. I don't know if I actually don't know, because there's around 25 different types of episodic ataxias or ataxia that is described. I don't know if it's officially known as one. Because episodic ataxia, if you'll know, is commonly seen with calcium channel genes. So CACNA1A is one gene which is like codified as a classic episodic ataxia gene, SCN2A as well. But I think there's certainly a portion of that that will develop over time. But there's these two types of ataxias, and the constant ataxia is typically associated with early onset degeneration of neurons in the cerebellum, for example, and it's just always present and can worsen over time or stay the same. Whereas episodic ataxia is a complex phenomenon where we don't quite know why it's so episodic, because it kind of is the same kind of features, but what episodic ataxia will look like is often confused with seizures, because what they'll have is sudden onset eye movement disorders and sudden onset of dizziness, and they'll have nausea, and they'll not want to talk, and it can often appear to be like a seizure. So often kids will be misdiagnosed with seizures when they're actually having sudden onset nausea and sudden onset eye movement disorders, which can look like seizure-like eye movements, but they're actually just sudden onset of cerebellar dysfunction. And what we'll see in both kids, yeah. Yes, my daughter has CACNA1A with the A2. Okay, but I was told there's a ataxia like a symptom versus the genetics. Yeah, for sure. I think what all of these sort of are, before CACNA1A was known to be associated with episodic ataxia, I think it was also just described as a symptom and we didn't really know. But what happens in these disorders is if you get enough patients with episodic ataxia that have a certain gene disorder, then it's likely attributed to that gene disorder, and then it's added on into the classification as a certain type of gene. So I don't think there's enough evidence or enough patients that I have read, at least with SCN8A, that have been described to have episodic ataxia, which is why it may not be a classic genetic episodic ataxia. But it can basically get added on, and that's how these classifications have grown over years. You just start to see more and more, and then you just keep adding them on, if that makes sense. But yeah, so episodic ataxia is important to know as well, because it can look like seizures. And so moving on here as well, I'll keep answering questions as they go along, if that's okay. And for specific tasks like fine motor skills, for example, eye is the number one. You can do specific tests to kind of discover that feature is kind of abnormal. So I'll show a picture of one kid here who has generalized ataxia, not episodic ataxia. And what we're going to do is we're going to be doing, this is Sarah, one of our physiotherapists, specialized physiotherapists at our specialty clinics. And what she's trying to do is a finger to nose test. So she's trying to get her to touch her nose and then touch the finger. And what you'll notice is you'll see a little bit of a sway when her finger goes, and it starts to get better, but she's also having what we call, I'll just go back here. So what you'll see in the first time she does it is that her arm sways a little bit. So you see that arm sway a little bit? That is called ataxia. So that discrete movement is already something we discovered. And then you can see that she has to touch the tip, but she's not really touching the tip. She's touching kind of somewhere in the finger. And that is called dysmetria, meaning they just can't reach a specific point. So these are both signs that there is some form of cerebellar dysfunction, because the muscles that are kind of coordinating the arm movement aren't able to tell the arm to move in a smooth fashion, and also can't tell the arm to move to a certain spot. And now we're going to ask her to do a special task to discover fine motor movement, is do rapid alternating movements. You saw this probably at the conference if you were there, we were doing this as well, is they have to tap up and then they have to tap backwards. And you can see that it's kind of uncoordinated here. So she can't really stop the movement of one direction and has to do the other side. And it starts off well on the left as well, but kind of becomes worse again on the right. It'll just like the right. So that we call also a classic sign of cerebellar dysfunction, where you can see that she's not really able to do these complex movements. And then when she holds her arms up, she's actually mostly okay. So she doesn't really have any clear damage there, but you can see a little bit of sway there as well, start to show up later on. So my kiddos like this constantly, but way worse at random moments. We have no idea why these random spells get worse besides the episodic. Yeah, and I think that is a very difficult thing to judge as well. I think the ataxia one is just constantly there. That's just part of the developmental issue, I think. But why some random moments make them worse? It can be anything. Just like seizures, there are provoking factors. So changes in electrolytes, because of course all the movements are coordinated by ion channels. So if one ion channel is deficient, any kind of electrolyte changes can impact the channel, even other channels that are not that same channel. So those things, fevers, anything could theoretically worsen it. Why specifically they worsen at that moment, I don't think I have an answer for that. But yeah, it could just be any diverse range of regions.
I wanted to jump in and ask a question. So, if you have a child or that cannot do these particular tests, because they're so low toned that they're unable to do those sort of things, are there other tests that you would be able to do to see if they're still suffering from ataxia?
Yeah, so I think a lot of the time just watching is enough. So if you watch the first kid that I showed with the hypotonia, I think a lot of the time ataxia, even though the arms and legs aren't really doing these kind of complex tasks, we just would look for sitting and standing. Because I think the balance and sway tells you how much there's. Because hypotonia by itself doesn't really lead to sway too much if you can balance them. But if you start to see a lot of sway, you start to see a lot of walking difficulties that are like, even if you support someone and there's still more sway, I think that's what we look for. And then we also look for eye movement disorders. I think they start to pop up at some point. So I think uh, doing eye movement is something we look at. Other than that, it becomes very tricky if there's not a lot of movement, because ataxia by definition requires movement to be able to discern whether their movements are uncoordinated. So we can look at gross motor function as a marker, but I don't think there's a lot of specific tests you could do to create kind of movement, if that makes sense. Yeah, and definitely. I think speech is also one of those muscles that needs a lot of, and I think, yeah, that's a good point, actually. Speech could also be part of this ataxia phenotype sometimes, because coordination of these fine motor muscles in the mouth and the tongue also can be affected. That is a good point. Yeah. Cool. All right. Awesome. We'll move on to the next person. So now it's talking about dystonia. And dystonia is one that a lot of times is confused with spasticity or tightness. But there are two different entities of kind of the same coin, but just led by different parts of the brain. But what dystonia is an abnormal contraction of a muscle due to uncoordinated neural stimulation. And you'll see there it says uncoordination. What the cerebellum does is kind of coordinate the activity levels, the activity timings, as you could say almost. Whereas the brain, the basal ganglia, where the dystonia stems from, is very important for the amplitude or how much a muscle contracts. And dystonia will lead to basically abnormal posturing because it leads to just constant activity of a muscle that overrides activity of its partner. So say, for example, your foot can be inverted completely, and it limits its ability to stand because your foot is basically always scooped up like a spoon almost. And the same thing can happen in the trunk. So you see a lot of turning of the muscles of the other intrinsic muscles of the back, and this can lead to scoliosis. So you can see that just because of the muscle, bone problems also start to show up. And this can also lead to, of course, respiratory distress, difficulty with sitting, and just general disability. And I want to show you first an example of a severe dystonia in one of our patients right here. And what you'll see is look at her neck, which is kind of turned to the left, and look at her arm, which is almost bent in this flexed bicep structure, and then extremity and the wrists are also kind of just tilted upwards. So they can't go down too much because the extenders of the wrist have taken over the function, and they were just constantly stimulated over time. And you look at how her neck just keeps pulling to the left side and how it keeps getting worse as well. And the same thing for the biceps, you start to see this kind of rigidity that is just constantly there. It doesn't change over time, it's just constant and makes it very, very hard. And when I try to sit her up again, oh, this works now. When I try to sit her up, you start to see that her mouth kind of also becomes dystonic. She's had her mouth is open. She can't really close it. And that's now the mouth muscles that are kind of open. And this is also a combination of dystonia and hypotonia because you see, you have to hold her up. She doesn't really have core strength anymore. So we'll never know whether she was hypotonic to begin with, then became dystonic, or all of it happened at the same time. But often there's a correlation between these two. So you can see that sometimes it loosens up, so there's a little more straightness now, but then she's kind of in the same position. So this is a very severe form of dystonia. Typically, dystonia is also associated with degenerative disorders over time or dysfunction of the basal ganglia. And there's been a lot of studies. I haven't added too much here because it kind of defeats the purpose, but basically some of our channels, like the sodium channel, are very important for the function of cells in these areas of the brain as well. We always think about the cortex where the seizures come from, but they're also, of course, in other parts of the brain. And dysfunction there leads to overactivity of neurons and can cause this kind of dystonia. So that becomes pretty severe. But dystonia can also be very discrete. So this is a video from our SCN8A conference. Some of you may recognize this person already, but it cannot really be associated with just severe motion abnormalities, but dystonia can emerge due to impairment of sensory perception. And I think this is where a lot of dystonia is really seen by us in our multidisciplinary clinics that we have at Houston, but also at these many conferences, where you get very, very discrete dystonia in the hands and extremities, because what a lot of our kids have, and this is something that we're working on now as well, is sensory impairments. So what sensory impairments mean is they can't really feel around them very well, and they can't perceive where they are in space. So a lot of the biting behavior, a lot of the touchy behavior that a lot of the kids who have more of the behavioral abnormalities have, and this is something that we see a lot of in non-developmental disorder autism patients as well, is they just don't perceive the environment. So they touch a lot, they bite a lot, and all of that is kind of to create this sense of feeling themselves or feeling their environment. And what you then start to see is, look at this kid, she's joyful, she's active, but look at her hands when she stretches them out. I just want to show, I'll pause it when I show what I want to show. Oh, let me go back. It doesn't really let me pause. It doesn't. So you can see it in her right arm already, kind of. You see how the fingers are kind of bending? But let me pause it when the left arm kind of stretches out. You see this kind of fingers. So when typically other kids will stretch out their fingers, so I'll focus on that and I'll start the video again. When they stretch out their fingers, if they're able to feel themselves in space, the fingers kind of are straight and going ahead. Whereas in these kids, they don't really know how the fingers are there when they're far away from the body, so they kind of flare out. They'll have one finger going down, one finger going up. They'll kind of turn around as well. And these kind of discrete dystonias are something that we're seeing more and more of, and they are probably what we call reactive dystonias, just because the person doesn't really feel them. So focus on the right hand. You see that when she lifted up, it kind of becomes like a paw. And the same thing there, when she's kind of stretching out, you see how the fingers kind of very intermittently will look kind of as if they're curling up. And that enough in itself is already indicative of a little bit of a dystonia, even though she seems to be jumping, running totally fine. So there's clearly something that has emerged, but is not really affecting her too much, but can affect her later on when this sensory issues persist.
There's a question in the chat talking, I think, more towards the first presentation of dystonia. And it
Uh-huh.
said, or it's asking, is dystonia linked to seizure activity? That her son has dystonia when he's doing poorly, meaning having, more seizures and maybe not feeling well, things like that. So most of the time he doesn't at baseline, but if he's doing poorly, she notices it.
Yeah, I think seizures can worsen a lot of things, and we don't really know why. It's probably just so the release of neurotransmitters that activate seizures are excitotoxic, so they kind of create this environment where everything kind of is stimulatory. So dystonia can worsen, and I think a lot of times we also have dystonic disorders where stimulation worsens dystonia. So just the activity of movement can worsen the dystonia. So just muscle activity. So I think in that way it is linked. I'm not really certain that the brain activity of the seizures kind of goes to the other parts of the basal ganglia and creates the seizure activity, but I think it is possible. There are some seizures that do activate the basal ganglia and cause dystonia. So those seizures are typically temporal lobes, so focal seizures which have a dystonic component quite prominently. But often we'll have to see what the seizures look like. But those are typically limited to the seizures, not worsening baseline dystonia. So they typically create dystonia for a little bit, don't really worsen baseline dystonia. I think worsening of baseline dystonia is just overall worsening of activity. Cool. Yeah, so those that I wanted to highlight because this I think is something that a lot of our patients at the conferences have noted and or we've noted and they did not know that that was kind of abnormal. And I think there's a lot of ways to kind of address this. So a lot of times patients will have like things to just stimulate them. So for patients who have like sensory issues of the core, we can do something like pressure jackets or vests. So these are like sensory vests where people will wear just tight vests on them and so that they feel themselves in space better and they actually have better core strength after that just because of the pressure so that they know where they are. And the same thing, there is gloves that they can wear for this kind of thing. So the gloves actually give them the feeling of touching and feeling of knowing where they are in space, and some of this dystonia has actually been shown to improve. So something to keep in mind that this is the kind of stuff that we can address with because it's secondary and not really a primary dystonia. I'm not really going into medications much because I think that would have taken over too much of the presentation, but we can talk about it at the end if we have time. Yeah. All right. And then I want to talk about chorea as well. So chorea is something that is involuntary dance-like movements is how you describe them. So people kind of moving around all the time. And they are often associated with dystonia. So they can have involuntary movement that then kind of jerk up and then they'll continue moving. And this can be very painful, very disabling. And I think this is one of those things that we don't really understand why it happens or in which patients it happens. And I think as I've been talking, I think the degenerative aspects are something that we really need to discover more about because these are disorders that you see in Huntington's and Parkinson's disease, known with older individuals typically. So why are they happening in our kids? How much degeneration of the deeper areas of the brain are we really seeing, and what is the cause of that? I think that is a great thing to understand. So just to show what chorea looks like, as you can see, I'm trying to hold this kid over here, but you can see his legs, you can see his face, you can see his body, his legs, all are kind of this rhythmic dancing like movement is what typically chorea look like, and I'll show that again. And this has been seen in SCN8A and other very severe cases. So yeah, something to note there. And then finally,
Stella.
my yeah.
Oh, I was just going to mention Stella has chorea, and much like the question before, I've noticed that it worsens when she's doing poorly. Like either she has, she's sick or excess, more seizures, things like that too.
Mhm. Yeah, I do think that there is a correlation in general. I mean, just abnormalities and imbalances in neural circuitry is very, very, and they're very vulnerable once they have this kind of circuitry. So any changes in like fever could do it as well. So temperature, of course, leads to higher excitability, can provoke this. So yeah, that is very much to be discovered. I think we don't know all the mechanisms, but it's just a generic kind of blanket statement from my side here, but I do think we see that. All right. And can chorea be sudden onset or episodic? Not typically. So typically it will not do that. I think episodic sudden onset chorea is typically associated with endocarditis or rheumatic disease or Sydenham's chorea, typically known. So that will be new onset chorea in an otherwise normal person. And that's typically in kids. And that is a special kind so the strep throat bacteria is what kind of can provoke that if there's a so that bacteria kind of is the classic Sydenham's chorea. Happened a lot in underdeveloped countries. So where I come from in Nepal, we see a lot of Sydenham chorea as well before antibiotics were readily available, and those kind of respond. Like episodic chorea, like episodic ataxia, I don't really know of. I don't think that exists too much because it's typically associated with like constant stimulation or basal ganglia dysfunction. So I don't really think that exists. Yeah. But of course, it could exist, and I'm not aware. But from all I've seen, is it's mostly infectious related or medication induced chorea. Yes, of course. So we have or strokes. Strokes can cause sudden onset. Yeah, of course. So like actual affecting the basal ganglia sudden onset, that typically is stroke related or medication induced. But and we've seen a lot of older individuals who have strokes of a certain artery where they affect that part of the brain, that part of the basal ganglia, that can have sudden onset chorea, and that just happened after a stroke. And typically, classic medications that help them, like anti-dopamine medications, will help with that as well. So that's how we treat them in adults. Yeah. All right, and then myoclonus is the last thing I think because Casey mentioned it's hard for a lot of the patients to know what myoclonus is. So myoclonus is actually just a jerk. So, and myoclonus does not necessarily mean anything pathological. I have myoclonus, you have myoclonus. I think everyone in this room or in this Zoom has had a myoclonus before. It's just a jerk that you have in sleep as well. So everyone has had like sleep moments where you just like jerk and you're like, what was that? That is a hypnic or nocturnal myoclonus that exists. Is not really a movement disorder, but it can exist for anyone really. Any patients with strokes can develop it, patients with brain injuries can develop it, spinal cord injuries, anything can really cause it. But there are also disorders where it can be very frequent when it's coming from the brain, and that can be part of a myoclonic seizure kind of complex. So it's a very diverse thing, and it's hard to really say like, oh, you have a jerk, you have really severe abnormality. It's just something to note and see if it changes in frequency. Because if it does, and this is what it will look like, it can have relevance. And you'll just focus on the left arm there. So you see that like intermittently, her left arm will kind of jerk up. So that is enough. That is a myoclonus. It can be it's very, very brief. It's microseconds kind of, and it's just a brief jerk. And it's not really evolving. It's not really changing. It's not really rhythmic either. Kind of comes and goes. And you saw how her finger kind of jerked up. And that was all it took. I'll show it again. And that's kind of what myoclonus is. It just comes and goes, and it could be multiple parts of the body. It could be one part of the body. You just have to really focus and understand whether it's coming from the brain, where it could be part of a seizure, or it's coming from the muscle or the spinal cord.
Is it possible that that myoclonus could be in the tongue, just like little movements of the tongues, or would that be something else?
Yeah, you can have myoclonus of the tongue. You can also have chorea of the tongue.
Mm-hmm.
So
Oh,
chorea,
okay.
so like a chameleon's tongue of like coming in and out, in and out,
Mm-hmm.
like dance like. So important is so movement disorders are all about rhythm. So is there a rhythm to it? Is it frequent? Is it changing in rhythm? Is it alternating? So those kind of things really matter. So chorea will be more of a rhythmic chameleon-like tongue coming in and out,
Mm-hmm.
around. I think that will be more of a chorea-like tongue movement, whereas a myoclonus of the tongue will just be a jerk. And it won't
Mm-hmm.
really come out. I mean, it can come out, but typically they'll just feel it inside the mouth. They'll be like,
Yeah.
oh, or a palatal myoclonus is something like the palate or where
Uh-huh.
the uvula is, that can kind of jerk up and down, and that can be very uncomfortable as well. So those are
Interesting.
kind of things that can occur. Because like the
Yeah.
tongue in Korea are the typical movements you see in Huntington's disease. You'll see like this chameleon's tongue is what they call them.
Yeah, sometimes I even notice like Stella's tongue will just kind of like be very quick, like
Sure.
move, triggering, but it's not a seizure. It's just, yeah, her tongue's doing a weird vibration movement, if you will.
Ah, yeah, so they can be like a high frequency tremor. So the tremor is something I'm not talking about here, but tremor is also
Hmm.
some high frequency tremor or some kind of activity there. Yeah. Okay. And of course, all of this is important. Why? Because it can impact gait, walking, and mobility, because of course, that is a big part of quality of life. So regardless of how severe or not severe a disorder is, everything can lead to any kind of gait abnormality, and that may not be super apparent, but it's probably there. So supportive medicines, devices, and individualized therapy are crucial for everyone, okay? And I think that is the essential part. So I want to show just for that this example of a patient who's not a severe. He doesn't have major dystonia. He doesn't have major chorea. He doesn't really have anything major. Now, uh, but he's actually also going to school and thinking of college. So he's like very further along in one of the milder phenotypes you see. But you watch him walk and you can see that when I'm trying to hold him, there is some abnormality. Look at the way his left leg is kind of curled towards the side. There's a slowness of the gait. There is an imbalance. You see him swaying a little bit, and that there's uh, and a little bit of coordination loss. So anything, and this is like kind of like a jump that he did, is also a little bit of the tone issues that we can see. So even the mildest phenotype or the most cognitively less affected person can be affected by this, which is why it's important to discover these things early so you can address them as best needed. Of course, this doesn't mean that we're just watching them as like a hawk. I mean, we do, of course, but just to monitor things closely and so that we can address them appropriately. All right. So now we know there's a lot of movement disorders. We've talked about why the movement disorders really matter. So how are we approaching this issue? And I want to present some of our research endeavors. So what we're doing is some of the videos you've already seen. We're using an innovative approach to detect these movement disorders and also quantitatively as best possible, understand them because the goal at the end of the day is have something that can be done across the country, across the world, objectively, so we can measure whether they exist, how they're improving with treatment, and whether we can use them in clinical trials, in the gene therapies, et cetera, that are coming in the next years. So it was me with some colleagues as well who helped use movement disorder scales to validate or to validate movement disorders to basically score individuals with certain disorders. And we use video recordings and video annotation software to kind of detect movement disorders over time. And what did we look at? So you'll see that a lot of the movement disorders that I discussed earlier are not represented here. It's because there is an issue inherent to the system that we don't have a lot of scales that are objectified and validated. So that already limits our ability to quantify movement disorders very, very well. And but we use four scales to describe spasticity, which I didn't talk much, which is more like tightness of the muscles. Van Marston scale, which describes dystonia at rest or in motion, the SOTA for the eye movements, which I'll not be talking about today, and SARA, which is measuring basically the ataxia, fine coordination, and addressing the ataxia realm. And what we were able to do so far is we went to all the conferences like the Kid Syndrome Foundation last year, but also other Gene Foundation conferences. And at the patients we see are multidisciplinary clinics for SCN2A and CACNA1A, CACNA1A in Houston. And we were able to identify already 144 individuals, which we have seen. And you can see there's a diverse number of patients. SCN8A, I will caveat this. A lot of the data, or some of the data I'll present, is just from 6 individuals we saw at last year's conference, and a couple we saw in Germany at the SCN2A and 8A Germany conference. So there's not much data to truly suggest that this is all we will see in SCN8A, and I'm just based on the questions, you'll already know that this is not entirely representative of the entire SCN8A population. But I think it's a good step in the good direction and we're trying to see how we can do that. So What I'm showing here, and it's a very busy plot, and I'll show you why. So what we're doing here is I'm trying to show you an overview across all movement disorders, and or across all our patients. And on the left here, you'll see different kinds of genes annotated and different types of variant types of those genes. So SCN2A has like three different types here, which could be loss of function or gain of function. Now, I'm not going to deal there, but I'll focus on the SCN8A group. And you can see that in the parameter scores for spasticity, dystonia, and ataxia, SCN8A appears to be milder than a lot of these other genes. And that is most likely related to the number of patients. But what you can see is that we have a diverse range of movement disorders and severity of movement disorders. And within genes as well, you can kind of start to see differences between these movement disorders. So our scales are clearly working and able to detect these disorders, but what do they definitively show? And I'll focus on that now. But of course, this plot is very difficult to understand. There's a lot going on. So we'll try and simplify these different kind of movements and the scales that we've done into basically scores that are easily understandable. So what we did is we have a lot of raw parameters for single arms and single legs. So say, for example, we look at dystonia as a raw parameter, and we're looking at right arm and left arm dystonia. We have created kind of composite parameters to describe extremity dystonia, or in this case, upper extremity dystonia as one parameter. And the same thing we're doing across the board. So for ataxia, we've kind of summarized movement disorders that are sitting, standing, and walking into gross movement. We have the coordination tasks like the finger to nose and speech, which is kind of separate to all of them. And through these summarized kind of parameters, through composite parameters, we can estimate what kind of disorder we're clearly seeing across the board. So this is a plot that shows basically are movement disorders present at all across individuals with NDDs, and it's kind of a good but also not great plot because what it shows is that what we see across the board is that the control patients are very well covered and basically show no real evidence of any kind of movement disorder. So that is a good control for us to say like, hey, our scales are clearly working. We're not quantifying wrong things here. We know that patients who do not have anything don't have anything, and that's good. And then the second part is, what are the movement disorders that we see? So we're seeing, and these are different scales, so bear with me there, but what we're seeing is that ataxia or coordination deficits, as well as speech deficits, seem to be emerging quite a lot. And spasticity, which is kind of tightness, but not really the dystonic kind of spasticity, isn't really represented much. It's a first start and gives a good overview that basically, hey, movement disorders exist and we see it clearly, and there's quite severe movement disorders as well. But there's also, as you can see with the dots here, I'll just use this as an example. You can see some are very severe while others are not. So there is a range of movement disorders. And our next goal, of course, and I'll not be presenting too much of that data here, is to show which patients are the ones that are really looking at are more severe, which patients are not that severe, and that's kind of the goal. But for today, I'll just focus on the SCN8A patients, and then once again, I'll caveat it, we only have 6 patients, but what we see is that spasticity is kind of not really something that we're really seeing, which is just general tightness of the muscles. This is something you see mostly in stroke patients, for example. But what we see is a lot of coordination deficits and deficits related to speech as well. So speech meaning production of speech, coordination of speech, that can be behavioral a lot of the times, or related to the autism kind of spectrum. But we're seeing those emerge. And instead of axial, we're seeing mostly extremity, upper and lower dystonia. And that was one of the patients you remember with the very discrete dystonia. That was, for example, her. So we see like she has like fine coordination deficits and this kind of discrete dystonia that emerges, but not really dystonia in the body. So she's not super affected. It just kind of emerges later on. So these are things we're trying to discover as we go along. And this is a different way of showing the same kind of data. So what this data shows is that the same data we're showing how much of the maximal possible score, or like how much of the severity score you're kind of seeing. So if someone had, for example, 10 points you can get maximally, are they getting the 10 points or are they at 50? Or how many proportion of these patients are getting the maximum points? And you can see that here again, the coordination and speech deficits, which may be related to the autism spectrum, are more kind of represented than some of these other severe dystonias, which we don't really see. All right. And before I move to the conclusions, I think there are some questions popping up, and it was in the peripheral vision. But so SCN8A CACNA, both of them very difficult to differentiate which were attributed to which. Yeah, I think, that is a great point. I think a lot of our patients struggle with that. And I think the important part there is we're not really treating the gene at this point. We're treating the symptoms. Of course, there are some gene disorders that have more of an effect, or more gene therapies coming up, and then we'll have to specifically see which one's more affected. But at this point, when there are things that we know we have options for, I think trial of options is something that we can commit to. So for example, CACNA1A has long been known to be a responsive to acetazolamide, for example, for the episodic ataxia. So a lot of the times, even though we don't know if it's CACNA1A or some other gene, you can try the medicine first and see if it responds. Because lastly, treating the patient or kids, I think, comes before kind of knowing it. And I think like discussing that with the physician, seeing like, hey, we don't really know which one it is, but maybe we can just try this and see if it responds, is the way to go, because you are in a way creating options for yourself to just treat and see what helps. But yes, I think that is a very difficult part. And I think we struggle with that at our centers as well. We often try to, with this phrase is termed as a genotype phenotype correlation. So we try to estimate based on what is known whether the gene matches the symptoms we're seeing, but often there'll be overlapping symptoms, like SCN8A, very severe version, can look just like CACNA1A, very severe version. Like, how are we going to be able to differentiate what truly is contributing? Or maybe there's percentages, 60% calcium channel, 40% sodium channel. How do you know? You kind of go both routes. So that's kind of the issue there. And vestibular PT has been great for my daughter with ataxia. Yes, absolutely. Vestibular PT, vestibular OT, those are great options for ataxia. As the name says, vestibular, they're more about the vestibular organ balance, but the vestibular organ and cerebellum both do balance. So I think the strategies they kind of provide are great for both problems. Yeah. Awesome. All right. So with that, I think I would like to conclude and not go too much into the data that we have to present. But what I want to conclude with this is that movement disorders clearly significantly impact the lives. All of you speaking in the chat has, of course, commented on that. And then what we see across these different genes also shows that. And we need more such innovative approaches to detect movement disorders. I think some of the things that will be developed in the future are, of course, tracking watches. So as you saw in some of the videos, there was a watch they were wearing. We have that component of our analysis as well. So we're trying to correlate how the watch is in comparison to the clinical scales. That will give us more broader objective parameters, maybe combining both of these things as well. So these are kind of the ways to go and try to characterize movement disorders better. And right now in SCN8A, we see ataxia quite a lot, or coordination deficits, but it's just a small cohort. And of course, I already know that there's a lot of SCN8A related severe developmental disorders, and you guys are talking about it. So we hope to capture these as well in the future and then characterize them better. And that will be it. And with that, I want to thank everyone and thank AC for including me in this. I am very humbled that I was, even though I'm just a resident and starting off, could be contribute to this and talk to you. And of course, thank you to all for being our inspiration and talking to us and joining. And I would like to thank all the physicians and Dennis, who is my research mentor, and all the people in the lab, our genetic counselors, our wonderful, our scientists. We all work together to create this. So I'm very happy to be in this group and be working together.
Oh, thank you so much. This was so informative, and I love all of the back and forth and the questions that were asked in the chat. And as always, you guys, I say you guys, their whole lab is amazing, and I really appreciate you taking the time to kind of
Mhm.
talk to us about the movement disorders. And I think the videos were super helpful. to go through those. And I know I made myself some notes and different questions that I have when Stella goes to see her disorder doctor next. And yeah, you were fantastic. Thank you so much. And thanks for everyone that joined us. I know it was kind of later in the evening, but we had a great turnout, lots of questions. And before we sign off, I just want to say thank you to our sponsors. We have Neurocrim Biosciences and Praxis Precision Medicine that were both platinum sponsors for this event. So that way we can keep bringing this information to you guys.
Thank
All
you. And I think
right.
a couple of questions about wearing
Oh,
watches. Yeah,
yeah, let's
absolutely.
jump into that real quick.
Yeah, I think we'll definitely be incorporating that further. I think there are some changes that are happening at UT, so I'm not quite certain if the whole group will be there at the SCN8A conference. I will definitely be there, but yeah, this is something we of course want to continue to do because more data is better, especially for these kind of devices. So I think we'll stay in touch through Casey, of course, and then ensure Dennis
Yeah.
driving that.
Yeah,
Yeah.
absolutely. We kind of even chatted with Dennis at one point in time if it could be something that some of this could maybe be done virtual
Yeah.
and send out the watches and stuff like that. So yeah, stay tuned. We have definitely had chats about trying to get more of our SCN8A patients in this assessment. Yeah, great questions. Awesome. One last chance. Any more questions before we sign off? I think that's it. All right. Well, thank you so much. And we will see you in a couple of weeks at the gathering.
Yeah, absolutely. Thank you. See you guys
Thank
there.
you. Bye,
All right.
guys.
Bye.